Oh, perfect. Okay.
Great.
All right. Okay. All right. Thank you very much. I have no disclosures for this talk. What we're looking to do is kind of review the relevant critical care literature published over the last year, basically since we were last here at this conference. And I'll give kind of a little bit of a rundown on the quality of the literature, some strengths and weaknesses associated with all of it, and then, potentially discuss some interesting points about each of the studies, along with maybe some of the applicability to bedside practice. One of the things that was pretty daunting when I was asked to give this talk was, first, I was excited that anyone would willingly want me to stand at a podium and talk, but then I got petrified because it caused some interesting introspection of like what the hell I've been doing over the past year and reading and all that sort of stuff. So in order to kind of come up with some articles and what I thought was a reasonable articles to focus on, took a perusing through the core clinical journals for articles kind of published over the past year, like I said, since we were last here, kind of chatted around some of our faculty and fellows, what they were reading, what they thought were some high yield articles, what they thought were kind of game changers over the past year. And then also went through kind of the foam critical care landscape, the free open access medical education arena, to see what folks were kind of talking about out in the blogosphere and Twitter and the scary world that is the internet. So the first study that I think is a good one to kind of start with and review and discuss is from Chris Seymour's out of the University of Pittsburgh, and it was published in the New England Journal of Medicine, and the title is "The Time to Treatment and Mortality During Mandated Emergency Care for Sepsis." And the clinical question they were looking at in this article was basically, is there an association between the timing of treatment and risk-adjusted mortality for patients with severe sepsis and septic shock? This was a retrospective observational study using the New York State Department of Health database. Just a quick word about that. In the state of New York, starting in, I believe, late 2013, early 14, they had instituted something called Rory's Law, which was basically a law that said every hospital in the state needed to have a formal protocolized approach to sepsis care, including sepsis identification and sepsis treatment. This was born out of a very, very sad case at actually my former institution, NYU, where a young child was basically died of septic shock at home because they missed it in the emergency room and he was discharged. So as part of that, the state now has a mandate that every hospital in the state, sepsis care, at least the initial evaluation and the initial resuscitation and treatment, is protocolized and monitored by the state. So these investigators looked at this database from the state from April of 2014 through June of 2016, looking at about a total of 185 hospitals. And the primary exposure was time to completion of the 3-hour bundle, and the primary outcome was in-hospital mortality. Now, the 3-hour bundle in this particular study in New York State was looking at patients with severe sepsis and septic shock, and then looking at the administration of antibiotics within 1 hour of initiating the protocol, drawing blood cultures prior to the administration of antibiotics, measuring a lactate within 3 hours of initiating the protocol, and then at a 6-hour kind of bundle or a 6-hour window, making sure they got, the Surviving Sepsis Campaign recommended 30 cc's per kilo of fluids, vasopressors if they were experiencing refractory hypotension, and then rechecking a lactate after the initial one was drawn. And so the inclusion criteria for this study and pulling people out of this database, they looked at folks who were over the age of 17, who had severe sepsis and septic shock as defined by the Sepsis 2 criteria, and then also had the sepsis protocol initiated in the emergency room within 6 hours of their arrival at the hospital. Folks who had the bundle completed more than 12 hours after the protocol was initiated were excluded. Anyone that had the bundle contraindicated was excluded. Patients who declined any sort of treatment were excluded. And then there were some hospitals in the state of New York that were fairly small, and so they had very limited numbers, and so those hospitals were culled out as well. And so about 111,000, almost 112,000 patients were screened, and about 49,000 were eligible. 82.5% of this 49,000 or so completed the 3-hour bundle within 3 hours. So the median time to bundle completion was about 1.3 hours. Median time to antibiotics was a little less than an hour. And median time to getting all of the fluids in was about 2.5 hours or so. And when they kind of broke it down between patients who had the bundle completed within 3 hours and patients who had the bundle completed between hours 3 and hours 12 of their presentation, the characteristics of those patients were fairly similar. No dramatic differences in terms of level of illness or anything like that. And so what was fairly interesting from this study and it doesn't necessarily project that well, but hopefully you have copies of these slides, is that each hour to time to completion of the 3-hour bundle was associated with a higher mortality. And so odds ratio of death until completion of the 3-hour bundle was about 1.04 per hour. And as you can see over here, looking at all patients, that was statistically significant. And so when you kind of break down the numbers a little bit further, patients who had the bundle completed during hours 3 through 12 had about a 14% higher odds of in-hospital death than folks who had those first 3 items in the 3-hour bundle completed within the first 3 hours. And when you do some additional digging among the various subgroups that they looked at, and as I highlight here in the red box, folks that were sicker, so those that had vasopressor use, those folks that came in, got fluids, and then had refractory hypotension requiring pressors, actually had a higher risk of death if their bundle had not been completed in 3 hours. So for sicker folks, the bundle definitely seemed, at least by kind of by observation here, be playing a pretty important role. And so this is one of the tables from the study, and it shows kind of the crude and predicted risks of in-hospital death, kind of across a range of times to treatment for some of the patients who presented to the emergency department. So on average, completion of the 3-hour bundle, if you completed it at 6 hours instead of completing it 3 hours, mortality was about 3 percentage points higher than those folks who got it completed in the first hour. A similar kind of relationship across the study population with a similar curve on the graph existed for folks with antibiotics. But what's interesting is when you do a little bit deeper dive into some of the patients, among the close to 27,000 patients who were eligible for and then had the bolus of 30 cc's per kilo of fluid administered and completed within the 12 hours, the time to completion of the fluid bolus was not associated with any sort of improvement in hospital mortality. As you can kind of see here with these odds ratios all crossing 1 and some pretty wide confidence intervals as well. So some additional analysis for this study showed that delaying collection of blood cultures and lactates was associated with mortality. So simply, if you just did not collect a blood culture before antibiotics in this study population, those folks did worse, with an odds ratio, again, of about 1.04 per hour, so a higher risk of death with each hour. And one of the other interesting things that I think kind of came up when you do a deeper dive into the literature here that makes this study a little bit interesting and a little bit more intriguing than at first glance is that hospitals that had a higher rate of bundle completion within 3 hours were somewhat smaller and less likely to be teaching hospitals, so less likely to be academic medical centers. So, just from a strength standpoint, obviously this is a pretty important clinical question and one that's pretty much on the forefront of the critical care arena almost on a constant basis of, time to antibiotics, fluids. Obviously at Emory we have a big sepsis VAP initiative to kind of work on this. It's an incredibly large data set, which is great, multiple centers of varying sizes and varying characteristics, and very real world kind of pragmatic data, and then additional statistical analyses kind of done on this study to really kind of tease out some interesting observations. With that being said, it is observational data, so can only describe associations. There's no causation here. At the same time, as someone who's interested in QI, when you really kind of tease this out, is this really looking at the effects of the bundle, or are we actually just assessing the effects of better functioning hospitals? So places that are a little bit just globally more efficient do this a little bit better, ergo they are able to implement the bundles and get them taken care of a little bit quicker. And I think one of the arguments that helps support this is the fact that drawing blood cultures before antibiotics was associated with an improvement in mortality. Drawing blood cultures in and of itself is not a treatment. Just an act, it's something to do. But for a place that functions a little bit better, that may be just part of their process. They function a little bit better, they're more efficient. I think when we, kind of dive into some interesting points to consider, I think one of the first things is the IV fluids. And when, the 30 cc per kilo bolus is a very hot item in general among the sepsis, in the sepsis literature and among critics of the Surviving Sepsis campaign. And I think when you criticize things, it's very easily to kind of misinterpret data. And I've actually heard some house staff here at Emory talking about, well, the 30 cc's per kilo fluid didn't have an effect on mortality. That's not exactly correct. It's the timing of the fluid did not seem to have an effect here, not the actual amount, which I think is important to kind of keep in mind and consider. The other thing is, why was there no effect seen with the timing of the fluid? The authors hypothesized that, sicker patients, By the mere fact that they were sicker, they were acted upon sooner, they were very likely to get fluid sooner, but because they were sicker, they were going to die anyways. So no matter what we did, no matter how much fluid we got to them, no matter how fast we got things into them, they were sicker, they were going to do worse overall. At the same time, rapid administration of fluid potentially led to some adverse effects as well: volume overload, pulmonary edema, longer duration of mechanical ventilatory support, poor outcomes overall. I think one of the other very interesting points to kind of come out of this and some of the secondary analyses is the fact that teaching hospitals seem to do a little bit worse with their bundle adherence. And when you kind of look at all the folks that love to wax philosophical about how terrible the Surviving Sepsis campaign is and how terrible their recommendations are, the majority of those folks are stationed in very lofty academic ivory towers. And so, you kind of wonder if, in general, academia, despite being the folks who kind of put out all of these recommendations, also kind of have this anti-standardized care bias simply because they're able to be at the bedside, or they think they're able to be at the bedside delivering more precise care, when in reality, I think when you kind of look at some of these larger numbers, that may not necessarily be the case. So moving on to a second study kind of in the ARDS arena that I thought was kind of interesting from the past year. This was the effect of lung recruitment in titrated PEEP versus low PEEP on mortality in patients with ARDS. This was published in JAMA in October of 2017. And the basic clinical question associated with this article was, does a lung recruitment maneuver associated with PEEP titration, according to respiratory system compliance, does that decrease 28 mortality as compared to a kind of conventional low PEEP strategy via ARDSNet protocol? And so this was a randomized controlled trial done in about 120 ICUs from 9 countries, predominantly in Europe and South America, and the primary outcome was 28-day mortality. They looked at folks who had moderate to severe ARDS of less than 72 hours duration and persistent hypoxemia after 3 hours of low tidal volume ventilation with a PEEP of at least 10. So everyone in this study was on at least a PEEP of 10 before they were included. Folks less than 18 were not included. Unstable shock. Anybody who had contraindications to hypercapnia was not included, which is interesting in and of itself when you think of some of the permissive hypercapnia that we allow with our ARDS patients. And then obviously anybody with a pneumothorax, sub-Q emphysema, that sort of thing, and then anybody that was moving in the palliative direction. So the intervention for this study was actually a little complicated, so I just kind of want to walk through it here. So once folks were deemed to be enrolled and randomized, they were paralyzed and switched over to pressure control ventilation with an inspiratory pressure of 15. They underwent a series of recruitment maneuvers up to a PEEP of 25 for a minute, 35 for a minute, and then 45 for 2 minutes. The PEEP was then moved to 23, and volume control ventilation was initiated. Static compliance were checked. And then the PEEP was down titrated by about 3 centimeters of water every 4 minutes, with static compliances being checked throughout this period. And then optimal PEEP was then found to be once the best compliance was achieved from those 3 measures, and then they just added 2 centimeters of pressure to the PEEP. And at that point, the patients were then maintained on volume control with optimal PEEP. The control group in this study was basically adhered to this table down here, kind of the ARDSNet, FiO2, and PEEP titration table. So about a little over 1,000 patients were randomized, about 500 to the intervention and 512 to the control. And interestingly, of the 500 to the intervention, 21 of them were pulled out after being randomized. The comparison groups in and of themselves were fairly well matched across level of illness. Baseline PDF ratios, were about 118 with this group, so pretty significant issues with hypoxemia. The pulmonary etiology to ARDS, about 2/3 of the cases were pulmonary, 1/3 were extrapulmonary. Interestingly, there was increased paralytic use in the intervention arm, which is not surprising based on the protocol I just walked us through. And so the primary outcome was mortality at 28 days, and there were 277 deaths in the intervention group, so about 55%, 55.3%, and 251 deaths in the control group, about 49.3, and as you can see here. So overall, really, the intervention actually seemed to cause more trouble than the control. And when you did some secondary analysis looking at some pre-specified subgroups, again, this table is a little small for this size of a room, but for folks that were, looking at their duration of mechanical ventilation before they were randomized, their duration of ARDS, whether their ARDS was extrapulmonary or pulmonary, how sick they were, there really was no signal, favoring lung recruitment. Sorry about that. And so when you kind of look at some of the strengths of this, obviously a multi-center randomized design is always looked upon favorably as we kind of go through the literature. And outside of the 21 that were kind of pulled out of the intervention, there was very minimal loss to follow-up, and overall protocol adherence as you walk through the trial was very, very good across the sites. With that being said, there was a lack of blinding across the investigators. And interestingly, the ICU length of stay was not included as they were undergoing their original protocol, but then was added into the statistical analysis plan afterwards, along with some modifications in their recruitment maneuvers in PEEP. So while it came across as a fairly rigorous study, you do kind of wonder what was going on the back end as they were kind of tweaking numbers and protocol to address things. And so, I think there are a couple of interesting points with this study that kind of affect us on our bedside practice. The first is, how applicable is this to our ICUs? These were ICUs in Europe and in South America. Obviously, there are local differences in care delivery, local differences in system practices. What's interesting also is the mortality in this group, pushing 49, up over 50%, is fairly high when you kind of look across other ARDS trials that are out there and even just look at ARDS observational studies. Mortality in some of the more well-known observational studies tends to hover around 40%, maybe 45% in some of the earlier ones. So this was a group that was either sicker or something a little bit weird was going on here where they were doing a lot worse. And so the question arises, how much of this is based on just differences in care practices at the bedside? In addition, I think, as we learn more and more about ARDS, we know there's a heterogeneity to its appearance. And the authors in this trial, obviously it wasn't on their radar screen, but addressing that heterogeneity and thinking about that heterogeneity, particularly in the form of fluid responsiveness and fluid resuscitation strategies, leads us to believe that there may still be some subgroups that are more likely to benefit from this recruitment maneuver. So I think immediately kind of throwing out the results here as something we're not going to use, I think would maybe be a mistake, looking at, again, some of the heterogeneity of ARDS. So the next study we'd like to talk about is adjunctive glucocorticoid therapy in patients with septic shock, or the adrenal study. This came out in the New England Journal earlier this year, and this looked at critically ill patients with septic shock, basically wondering, does hydrocortisone result in a lower mortality? And so this was a randomized, double-blinded, placebo-controlled trial. The intervention was an infusion of 200 milligrams of hydrocortisone per day. The primary outcome was death from any cause at 90 days, and this was done across about 69 ICUs across the Australia, the UK, New Zealand, Saudi Arabia, and Denmark, and it ran from March of 2013 to April of 2017. Folks with septic shock requiring vasopressors, mechanically ventilated, so a sick population, and anybody that had already received systemic glucocorticoids for another indication or was likely to were not included. Anybody that received etomidate or ampho, and anyone that was likely to die from a pre-existing disease within 90 days of randomization were DC'd, along with folks who had been sick for over more than 24 hours. So this got folks pretty early, which I think is an important component to it. So they screened about 22,000 patients. 3658 were included in the 90-day analysis. 1,832 were randomized to hydrocortisone. 1,826 were randomized to placebo. The baseline characteristics were evenly matched across the board. About 1/3 of these patients were surgical admissions. The primary site of infection in these patients was pretty evenly matched. Pulmonary was predominantly the primary site of infection for the medical patients, and an abdominal origin was probably predominantly the site of origin for the surgical patients. So with regard to the 90-day, or with regards to the primary outcome, at 90 days after randomization, 511 of the 1,832 patients who had been assigned to receive hydrocortisone had died, so 27.9%, as opposed to 526 of the 1,826, so 28.8% for placebo. So 27.9% mortality for the hydrocortisone, 28.8% for the placebo group, with no statistical significance between them. And as you can see from our graph here, you can see the curves pretty much overlap with regards to their survival. And when you dive into some of the pre-specified subgroups and look at the primary outcome, there really wasn't much different from what we saw in that prior graph. Really no significant difference in mortality among some of the pre-specified subgroups, particularly folks who are on higher doses of pressors, whether their source of infection was pulmonary versus abdominal, and then time from shock onset to randomization. Pretty much everything across the board suggested this was a negative study from the primary component. What's interesting about this study is when you dive into the secondary outcomes. So the hydrocortisone group had significantly reduced median days to resolution of shock, 3 versus 4, median time to cessation of initial mechanical ventilation, median time to discharge from the ICU, and use of blood transfusions. There were no significant differences among the secondary outcomes with 28-day mortality, the recurrence of shock, or the number of days alive and outside the hospital. When you dive into the adverse events, the serious adverse events, there were 4 of them in the hydrocortisone group, 2 myopathies, 1 ischemic bowel, and 1 circulatory shock, and then 2 in the placebo group, 1 of which was significant bleeding and another 1 of which was abdominal wound dehiscence. So, when we look at strengths and weaknesses, obviously this is a randomized blinded design, multi-center, incredibly large sample size, actually the largest sample size to date, looking at folks with septic shock and steroids. Now the weaknesses, I think, long-term neuromuscular weaknesses is a popular entity that we talk about when we start throwing steroids at people in the ICU. That really wasn't assessed. Obviously, it's somewhat difficult to assess it, but it still wasn't kind of definitively talked about with this trial. And then there were, at various points, some patients in both arms received some open-label steroids during this trial as well. And I think, from a discussion standpoint, the main point centers around these primary versus secondary outcomes. This is a negative study from the primary outcome. We did not see a mortality difference from the use of hydrocortisone. When you dive into the secondary outcomes, there is some interesting data there. There are some interesting results. And so how do we interpret them? Are they truly just hypothesis generating for the next study? Or, as all of us, have been standing at the bedside watching someone just floridly decompensate in front of us and just do terribly, is this study and the fact that there was some noise in those secondary outcomes, some meaningful noise in terms of less days in the ICU, a little less mechanical ventilation, is that enough fuel for us to kind of act in the face of, pretty significant critical illness? I think it's an interesting element to think about going forward as we use this. So the last study I'd like to go through here is the balanced crystalloids versus saline in critically ill adults done out of the folks up at Vanderbilt. And this was published a couple of months ago in the New England Journal. And this looked at, in critically ill patients, does the use of balanced crystalloids as compared with saline reduce a 30-day composite outcome of death, new renal replacement therapy, or persistent renal dysfunction? So it was an unblinded cluster randomized trial done at 5 ICUs at Vanderbilt looking at sodium chloride or normal saline versus lactated ringers or plasmolite. And the primary outcome was a composite of patients who met 1 or more criteria for a major adverse kidney event within 30 days or at hospital discharge. Those being death, the new receipt of renal replacement therapy, or persistent renal dysfunction, which was deemed to be a significant bump in the creatinine. Inclusion criteria were all adult patients admitted to the ICU, and only folks under the age of 18 were excluded. Almost 16,000 patients enrolled, about 8,000 to each group of balanced crystalloid versus saline. The median age was 58. The study groups were fairly evenly matched. Mechanical ventilation was present in about 1/3 of patients on both sides. A quarter of patients or so were on pressors, and about 15% had septic shock. When you look at the primary outcome here, a total of about 14.3% of patients in the balanced crystalloid group versus 15.4% in the saline group had a major adverse kidney event. And as you can see here in this table, statistically significant with some significant odds ratios there as well. Interestingly, when you do the math, this corresponds to a number needed to treat to avoid one of these adverse kidney outcomes of about 94. When you look at some of the secondary outcomes in some of the pre-specified subgroups, particularly among those with sepsis and septic shock, as you can see right here in the box, folks that were dealing with sepsis or septic shock had a significant favorability profile towards balanced crystalloids. When you dove into some of the secondary outcomes, death before discharge or at day 30, 10.3% in the balanced crystalloid groups, a little bit lower in the receipt of new renal replacement therapy, and no really significant difference in persistent renal dysfunction, which was about greater than 200% climb in your baseline creatinine. No significant difference in ICU-free days, ventilator-free days, vasopressor-free days, or stage 2 or higher acute kidney injury developing after enrollment. This was a very large sample size, very mixed patient population, and a very impressive, successful allocation of fluids and the way they designed the study. The downside is this is a single center study. There was a lack of blinding. Everybody knew what the fluids were going into each patient. And for folks that were in the ICU at the end of the 30-day study period, they actually then may have been exposed to both types of crystalloids going forward as the study ended and treatment or discretion was at the physician treating the patient at that point. I think one of the interesting points from this is that there were about 340 or so patients who had their allocated, they were randomized into the balanced crystalloid group. That was overruled in the favor of normal saline due to the presence of hyperkalemia. And as a pulmonologist, it's always a little troubling to go south of the diaphragm, particularly when there's nephrologists in the room. But in general, there's a decent amount of evidence that says, normal saline may actually be worse for folks with hyperkalemia given its associated hyperchloremic acidosis, the fact that it may exacerbate the hyperkalemia due to shifting of hydrogen ions intracellularly in exchange for potassium. So you wonder if this 348 patients had actually been maintained in their allocated balanced crystalloid group, we actually might have seen more of an observed difference between the groups. I think one of the other elements that needs to be kind of taken into account with this study is that this was a composite outcome that they looked at. Death, new receipt of renal replacement therapy, or a climb in their creatinine over 200%. That was pertinent to this study. In other studies looking at adverse kidney injury or the effect of balanced crystalloids and normal saline on renal function, the outcomes are a little bit different. So as we kind of look to merge studies or look to kind of compare and look at trends over time among these studies, I think these varying outcomes need to be kept in mind. The Elaine study, looking at RRT, basically showed, defined persistent renal dysfunction as a decline in GFR by about 25% compared with baseline, which is obviously a different outcome than this study. And so with that, I've managed to bounce into somebody else's trial. Oh, all right. I don't know what I've done. All right, so we're all set. Thanks.